All right, good morning. This meeting's called to order. Welcome to our June 8th board meeting. Our meeting will continue to be hybrid. The Healthcare Authority staff will be on site as much as possible, and other attendees. Both board members and the public will have the option to attend on site here in Olympia or via Zoom. For our Zoom attendees, our opening slide has information about how to turn on closed captioning subtitles. We're going to do a roll call. Harry Bossy.
Present.
Kurt Spiegel.
Present.
John Comerford.
Present.
Tom McRobert.
I'm here.
Michaela Dolman.
Present.
Awesome. Elliot Weinstein.
Here.
Monica McLemore.
Chair McDermott, we anticipate her being later to the meeting, and so
Okay.
Mackenzie will make sure we're aware when she pops it virtually.
About 11 o'clock?
Yeah.
Okay. And Katie Hatfield.
Hello, everybody. I'm filling in for Michael Tunick for the first little bit of this meeting until he can join us from court.
Awesome. And Katie's from the Attorney General's office, and just explaining the rest. And I'm Lou McDermott. I'm filling in for Sue Birch as Chair Pro Tem, as Sue is currently away on business. It's real nice to be back. And I'm the Deputy Director here at the Healthcare Authority. With board members attending both in person and virtually, it's helpful for the board to hold their questions until each presentation's done or when the presenter pauses to ask if there are questions. Board members, we will also watch in case you have your Zoom raise hand or your real hand, since you're in the room, to indicate you have a question. We have one resolution scheduled for action today, and the public will have an opportunity to provide comments regarding the resolution during normal procedure before the board votes on the resolution. The public will also be able to provide general comments at the end of the meeting during the public comment period. As a reminder, if the public has questions during staff presentation, the presenter's contact information is included at the end of the presentation, and you're welcome to email them during the meeting to capture your question for response after the meeting. Dave's going to provide us an overview of today's agenda. Hey, Dave.
Good morning, Chair McDermott, members of the board. Before I go through the agenda, just a couple of announcements. Before the pandemic, TVW participated and was recording and capturing and logging and putting into their archives and broadcasting some of the PEB and SEB board meetings. And that hasn't happened for a long time. But starting today, TVW is back. They're not physically in the room, but with a virtual world, they're capturing this remotely and doing the same thing. So I just wanted you to be aware. We appreciate that TVW is taking interest in a lot of the public board meetings throughout state agencies. It really helps make sure that the public has additional access to information, and we all know that there's a lot of importance and complicated aspects to healthcare, and the more the public can see and experience the presentation and the context that's provided in addition to the slides themselves can just help further understanding. So we appreciate that commitment in our state to TVW and the support they do for access for information to our citizens. Second, I just have to remark that for me, it's the second meeting this month where we've had so many board members, but for the PEB board, this is the first meeting where we've had so many members in person since before the pandemic. And before the meeting, Elliot was even commenting that this is her first in-person meeting as a board member. And it's one of those times where you go, how? That doesn't make sense in my timing, but it's really nice to be able to have people in person. But then it has me do things like, remember, if there's an emergency, we're all going to cross the street and go into the parking lot back here that I'm pointing to. So if you haven't been here before, but if for some reason we need to evacuate the building, it's just good to know where we're going. Again, cross the street in the visitor parking lot. And bathrooms, if you go out the back door here to the right and head down the hallway, you'll see elevators, but the bathrooms are on the left. So just a couple of housekeeping pieces. Now into the agenda, we will start off. We have a little bit of follow-up and the minutes from the May board meeting. Then we have bringing back the stakeholder feedback and the UMP hearing instrument benefit resolution that was introduced at the last board meeting, and hoping the board takes action on that today. Then we have two more resolutions for teeing up, not for action today, but to begin that stakeholder process. The first relates to the high deductible health plan rules that are governed by the IRS, and they are raising the minimum deductible, and so we have a new approach that we'd like to propose to the board for how to manage those changes in the future. And then we thought we would have a good summary of the unwind of varied COVID policies, especially with the federal public health emergency ending last month, and some of the implication that has for the agency, for the state, not just the PEB program, but also Medicaid, and just provide some context there, in addition to a resolution about covering some over-the-counter COVID test going forward beginning July 1st. So there's a resolution related to that. Then after a break, we'll shift into some conversations about our retiree and specifically Medicare portfolio. We've been working very diligently on a state-by-state benefit analysis. Those things are much harder to do than one can imagine sometimes. But talking about what the state of offerings are in the Medicare space in other states. Preview of coming attractions, we're quite unique here in Washington. That can be a good thing. And then we'll have Ellen back for some additional Medicare updates. There's always something to talk about our progress with retiree engagements or other aspects of the portfolio. So Ellen's just a standing member of our board meetings. And then we'll move into an executive session to talk about where we are in the rate setting process as we start to lean forward into the rest of the board season and bring you rates for both Medicare and non-Medicare for passing by the end of the season. And that's what we have as our agenda today.
Any questions for Dave? All right, our first agenda item is approval of the May meeting minutes. They're behind tab number 3, and Dave, I believe you've got an amendment to those minutes.
I do have an amendment, Chair McDermott. If everyone wants to, feel free to turn to page 3. In the public comment period, after we published the board materials on Monday, one of the members who attended last meeting noted that the description of their comments referred to the wrong topic. So I would like to suggest that what I say right now be rolled into a motion to pass the minutes as would be amended. So for Matt Groshong, it would say regarding the input process on the legislative report related to retiree listening sessions in lieu of a reference to the Kaiser First Fill program. So again, the what I would propose for that change, and he contacted us and asked that this be reflected on the record, that it would say instead regarding the input process on the legislative report related to the retiree listening sessions. And so that's I would hope that people will have that in the record, that that is what the page says, and that anyone who moves would move as amended, as I just suggested, be amended.
Speak up.
This is a minor thing, but and no offense.
Turn on your,
Oh.
you're good.
This is a minor thing, and no offense, Lou, but I think Chair Birch was here to open the meeting, right? Called to order? It lists Lou opening. It was Lou last meeting? No, I swear it was.
Yeah, it was.
Was
I
it?
did the
Oh,
last one, yeah.
My apologies, okay.
That's all right. You got Sue on the brain.
But for the record, at the top, it says members present, Sue Birch,
Yeah,
chair.
that's-
So that should say Lou McDermott, pro tem chair.
Gotcha.
So
All right.
2 amendments that are being rolled up into this. On page 1 at the top where it says members present in Olympia, that will refer to Lou McDermott, pro tem chair. And then at the end, the reflection that I just said about Matt Pershing's summary of his public comments. So thank you, Kurt, for catching that.
Eric?
Yeah, Dave, just for clarification, will those 2 amendments be reflected in a written document that is available online?
Yes, we will. Yes, Harry, assuming the board passes them with those amendments, we'll have those updated, and then the final version that's approved will be the version that exists on the website for the formal record.
Do we have any additional comments or corrections from the board? Do I have a motion to approve the minutes as written and amended?
So moved.
Do I have a second?
Second.
All in favor, say aye.
Aye.
Any opposed? Hearing none, May 11th, 2023 minutes are approved as written and amended. All right. Next agenda item is the May meeting follow-up. Dave?
You can go ahead and sit down. It's fine. Janice was anticipating the one after this. For a quick update, at the last board meeting, I described where we were on our Benefits 24/7 online enrollment system launch. There's no materials here in your book, but I wanted to give you an update on where we are on that project. We had originally anticipated that we were going live on Monday, 3 business days from now. As we were doing some of our final end-to-end testing, we came across some things that it's going to be better for everyone for us to not launch that IT system on Monday. So we're kind of in evaluation mode for the exact date for later this summer. But I wanted to give a little bit of a preview, and we're putting some messaging out today to both employers, school districts, because this impacts both the SEP program and the PEB program and our kind of wider communications. But one of the things that really made me feel that it was necessary to postpone that launch date was as we were doing the final end-to-end testing, some of the pieces that ultimately translate into the billing files weren't consistently performing. And it does no one good if a coverage chain or billing practices, billing amounts or premiums we don't have 100% confidence in that. So that's an extraordinarily important piece of this. And so I just wanted to add that transparency as to what is the reason for the delay. We're being as responsible as we can about the important pieces that translate us all the way into the billing files. And it's that last billing file component that has the most significant concern that just was not confident with saying push the button, go on Monday. It's going to be better for everyone to have us have that ticked and tied up, where we purposefully originally planned to launch in the spring to give us more space before open enrollment. And so now we're just utilizing some of that space. So we're really committed to making sure that this launch goes well, from plan changes, enrollment, not having to use paper if you don't want to, all the way into the billing files and the premiums that are collected. And so that's where we are on that project. So a little bit more information, but it's not going live on Monday. And so we'll be changing some of our communication pieces and when those follow out. And we may even have to resend something because we know that proximity to the launch for some of the information we send is really important. When you get something in the mail about what you need to do next, the closer it is to doing that action, the better it is for everybody. So we'll just be reworking some of those pieces. But I'm still extraordinarily excited about the momentum we have. And we're almost there, folks. In being able to have this, I say move the PEB program out of the horse and buggy era into the car area for our enrollment system. So that's my update.
The electric car era.
The electric car era, yes.
Do we have any additional thoughts or comments or questions from the board? Yes, ma'am.
This is not directly related. This is appropriate that I don't even know how to use a microphone. I appreciate your response, I believe it was last month, when I noted that a lot of older members, retired members, such as myself, don't know how to work the state system, and I forget what it's called, but the one you have to get into before you can even get into the SAW. And what is that called? What does it stand for?
Secure Access Washington.
Right.
SAW.
That one is also a dinosaur. That one is a dinosaur, and it's difficult for people to get into. And I appreciate the fact that Dave advised me that there will be people who answer questions about how to work SAW at HCA as well, because we need it.
Yeah, Elliot, we're really committed to the SAW process. If you're interacting with various parts of state government, at some point you will have to enter SAW. More and more pieces are being put behind that multi-factor authentication system to really have more security for the citizens that are interacting with various parts of state government. But we're working on videos. We have kind of a pictorial how-to that is something that has screenshots that one can walk through, in addition to kind of a customer service number that will be able to have people, also retirees, be able to help with that question. So a couple of areas of commitment there.
And Dave, wasn't there talk of SAW getting updated as well?
I believe that, that's the thing about IT security is it always needs improvement and always needs changes.
Yeah, so I do believe they're working on that as well.
So,
Yes, sir.
So that training that I did with Shatrina, that was the SAW update that you're talking about, and they're still working on it. Is that what you're saying? It was very good, by the way.
Yeah, the training that Tom, you were part of some focus group testing that we did and user testing, and that did inform some of the materials that we're creating or created at this point, since we were planning to go live, but that are created to help people walk through that SAW process. What has changed is not SAW itself, but how we're training and the materials to help people walk through that process. But Chairman Dermott is also noting that the state in general is looking at some refreshes on SAW itself. I'm not sure the timing of that related to when we would go launch, but if there is any change, then we would reflect that in our materials too.
Other questions or comments from the board? All right, Dave, thank you. Next up, Janice McAlpin, Senior Account Manager in the Employees and Retirees Benefit Division, is joining us to present on the vote for the UMP Hearing Instruments Benefit Resolution. After Janice reviews the resolution with us, I'm going to ask for a motion to adopt. A second, I'll invite for public comment. I'll ask for discussion from the board, and then we're ready for a vote. Her materials are behind tab number 4. Welcome.
Thank you. Good morning, Chair McDermott and members of the board. For the record, my name is Janice McAlpin, and today I am apparently very eager to present on UMP hearing instruments because I came up here early. Moving on to the next slide, I'll cover some follow-up from our May meeting. So there were a couple questions, and I took back and confirmed that the over-the-counter hearing instruments that I presented on confirmed the coverage in our health savings account. Those would be covered, as well as our flexible spending arrangement, the FSA, that would be covered as well, but not in the limited purpose FSA, because the limited purpose FSA, it only covers for dental and vision. So that was one specific follow-up item. The other one was a question about under House Bill 1222, are cochlear implants addressed? And they're not specifically because the bill calls for coverage of bone conduction hearing devices, and that does not include cochlear implants. So those specifics were not included in our fiscal analysis that we did. All right, so moving on to the next slide, I'll cover some more specific follow-up questions that we had. And per question from last month, we went back and did a review of neighboring states' hearing instrument coverage. And what we saw was a lot of variability. You can see the overview on the slide of Oregon, Idaho, and California. At a high level, what we found is that these neighboring states have a lower benefit amount, and many times it's subject to deductible or coinsurance, and it's often paired with a limited network. You'll see that the states appear to only mandate coverage for children and not adults or retirees, and we also found that the age of children greatly differs. We saw children age ranges anywhere from 0 to 26 years, but there was no consistency across those different states. And so our Washington benefit under the proposed resolution for action later, it's for UMP and it's for children, adults, retirees, and it's not subject to deductible or coinsurance unless you're enrolled in our CDHP plan. And that also includes broad network access for member choice. So there's an update on our neighboring states, and going on to the next slide, I'll cover where we're at currently with HB 1222. So the governor signed that on May 4th, and that will be effective January 1st of this upcoming year. That impacts the general large group commercial market health plans, including employees and dependents of all of our PEB and SEB program plans. And that will require coverage for hearing instruments at no less than $3,000 per ear with hearing loss every 36 months. So just a quick reorient on where that bill is at. And going into the next slide, I'll cover a couple examples of implementation. And this slide is going to look very familiar to what I presented in May, but I did want to call out that I did add one more bullet, and it's the fourth bullet based on some stakeholder feedback that we received. And so we decided to add bullet 4 as an example, just to be clear on implementation. We don't historically recodify or repeat all requirements from applicable statute in board policy resolutions or even program WACs. And we do this to minimize the chance for inadvertent conflicts between a board decision and the statute that's enacted by the legislature. So this resolution is focused really on the board's discretionary decision-making authority related to that specific benefit limit amount of $3,000. Just a couple examples of implementation again. And moving on to the resolution, reminding you of that language there. This slide is identical to the language from last month. There are no changes. As a recap and what you can see in your board materials, many stakeholders provided positive comments. One stakeholder proposed to be clear that it would be without coinsurance, but we feel like the language in there that says without member cost share in that first section, it's really clear and it already covers that. And again, what I had mentioned on our previous slide on that fourth bullet of the implementation example, we received some comment from the OIC regarding a specific section in the legislation that discusses that specifically. We didn't feel like it was necessary, again, to include that in this resolution because it's mandated in the legislation and we don't need it to be clear in the resolution. So we're bringing this forward to the board for vote and setting that specific benefit limit. And so at this point, I'll turn it over to Chair McDermott.
Chair McDermott, one more piece of information. The SEB board did pass the identical resolution for the SEB program last Thursday.
Thank you, sir. We're about to take a vote on Resolution PEB 2023-03, UMP Hearing Instruments Benefit. Resolved that beginning January 1st, 2024, prescribed hearing instruments in all uniform medical plans will be covered up to $3,000 per year with hearing loss at least every 36 months without member cost share. Coverage for members enrolled in the UMP Classic, UMP Select, and UMP Plus are not subject to the member meeting the plan deductible. Coverage for members enrolled in UMP Consumer Directed Health Plan are subject to the member meeting the plan deductible. Is there a motion to adopt?
I make a motion to adopt.
Is there a second?
Second.
Are there any comments from the audience? Do we see anything online?
Start with Fred.
Fred Yancey? Sir, you are up.
Good morning. Mr. Chair and members of the committee, Fred Yancey. I'm speaking on behalf of the school retirees. I, of course, written a letter to the board outlining our concerns with this policy, and I'll just highlight a couple of remarks. First of all, should this policy have been in place last year, 1,000 people would have qualified, would have got hearing aids that fell under the $4,000. However, 2,505 members will have been denied coverage for a more expensive hearing aid. That's a substantial. This policy would be a substantial loss of benefits for those 2,505 people. So we view this as a loss of benefits with, and lacking some information. And the information I'm lacking, just to fully understand, is and I don't understand the hearing aid market, but what do you get for $3,000? Do you just get basic hearing? Because there's a whole wealth of features connected to improving one's quality of hearing. It's more than just, hearing kind of at a gross, base level, but there's enhancements that add to the quality of hearing. And I don't understand what you lose when you go to 3,000 and less, or what you gain when you go above that. So with that in mind, I just want to raise our concerns for consideration by the committee, and thank you very much for your time.
Appreciate your comments, Fred. Do we have other comments from the audience?
Amy Fortier.
Amy Fortier? Amy?
Yes, thank you, Chairman and members of the board. I just wanted to comment that I share a couple of Mr. Yancey's concerns, but I think that some of those concerns may have been brought about by perhaps a lack of communication or notification to potential impacted benefit receivers. And I have noticed there's been an increase in transparency and ability to communicate out to both retirees, of course, and other members of the plans, which is excellent, and I commend you for that. However, this is happening now, so there may not have been the level of participation and input from those who are impacted. And I would just recommend that the level of impact be more widely noted prior to any type of vote. And also if it could be done in advance, greater than 30 or 60 days. Thank you.
Thank you, Amy. Other members from the public? Seeing none? Comments from the board? Yes, sir.
So Janice, I am curious, if we were to adopt this resolution, what types of hearing instruments would probably no longer become available to people who need them? Do you have any idea what that would be look like?
Are you asking for like specific models?
Yeah, I mean, I did a little research, and actually from what my research tells me, $3,000 per year is actually pretty generous. And I have some friends of mine who just recently have gotten updates or upgrades on their hearing instruments. And they were actually pretty impressed that would almost double what they had to spend, or would have had to spend had they not had health insurance. So, but that did strike me as what kinds of things, because Fred mentioned, there would be some adverse effects for some people. What kind of hearing instruments, are more expensive than $3,000 per year, I guess? And
Tom, can I add a little nuance to your question
Yeah.
too? This doesn't mean that folks can't buy the $5,000 hearing aid. It just means that it's covered up to 3. So they're not excluded from the higher end, but obviously there's a financial cost. So
Yeah.
I just wanted to add that little piece.
Yeah. I don't have any specifics on like which models that would take away necessarily, but like what Chair McDermott said is that our coverage would provide up to $3,000. So if a member wanted to go and purchase the more expensive ones, they would just have that difference. If they decided on a hearing aid that was $3,500, they would have to pay the extra $500 that we wouldn't cover. But I think what we included in the data and the utilization that Sarah, I think, had presented on previously is that we thought that limit would cover all those necessary items for those hearing aids. But do you recall the specifics?
Yeah, so this is where it starts to get into anecdote a little bit, but some of the things that we discovered were maybe some of the ways that a hearing aid can interact with your cell phone on an app, or the amount of data transfers that can be sent to your provider automatically. Sometimes like with a heart defibrillator or something, there's things that just kind of like transmit through the ether, things like that, or maybe the materials that are used. The analogy or description that we've used in the past was this sort of happened with pediatric vision hardware, where under the ACA there was a requirement to cover hardware, and there was not a lot of guardrails around that. And so there were instances where a Gucci glasses for a child might be secured, and that was covered because it was an unlimited benefit. But the spirit of what was required by the ACA was requiring hardware. So insurers, employers started putting some guardrails around some reasonable expenses for what would be, unnecessarily cosmetic aspects. And so, we see a wide range of hearing aids, but I think one of the reasons we brought back information about comparing some of the sister states was to your point, Tom, that this $3,000 benefit is really robust in comparison to our sister states, as well as it matches what we were seeing as the kind of typical expense within our portfolio. The other piece that I think is important to kind of respond to is we were doing a retrospective analysis of the decisions people made with an unlimited benefit. People would have acted differently, both providers and the member that's purchasing it, under different rules. And so, yes, a retrospective look back, 2,505 people fell differently on the spectrum over a $3,000 benefit. But all of those people may not have acted the same way if they had a $3,000 benefit. So it's a subset. That to me is a high watermark of potential impacts. But I do want to remind that we had hearing aids, I believe, Sarah, that went all the way up to $18,000, $19,000 for a set of hearing aids. And that really does manifest as there are some aspects to hearing aids that simply may not be necessary for everyone.
Dave, would it be fair to say too that the market probably will have some adjustments as well? I'm not saying the providers were gouging us, but knowing it's an unlimited benefit probably increase the number of hearing aids at the higher prices.
Many providers were aware of our current benefit design and were acting within the rules of our current benefit design, and there will be awareness of a different benefit design should this pass.
Yep. Other comments from the board?
Yes.
Elliot?
I would really like to vote for this proposal. However, I need to see that there is a direct correlation between cutting this benefit and a reduction in premiums. I haven't seen that yet. I've seen assumptions of downward pressure, and I totally believe that, but are there any examples from other states where this kind of action was taken and premiums were reduced? And I remember, Dave, you're saying there are so many factors that affect premiums, but I would still like to see if there is any effect rather than an assumption on reduction of premiums. And I haven't yet seen that, even though I frankly would be happy to see that.
I think hopefully what I can share right now will be helpful, and please let me know if there's additional pieces I get. Generally, again, looking at kind of the analysis, the comparison that Janice was describing, most states don't have adult hearing mandate coverages. And so those that do, it's usually an expansion. So that's going to be upward pressure because you're adding a benefit. So we didn't identify another scenario where it was going from an unlimited benefit down because it's simply rarer to have adult hearing aid coverage to begin with, and those coverages tend to be lower than what is even proposed under this resolution. But with that said, and this is very challenging because of where we are in the rate process, and so I can give you a specific incremental impact without the context of what the overall rates are. What I can tell the board is that when we are bringing out the Medicare rates, intended hopefully later this month, that an increase to the Uniform Medical Plan premium, if this resolution didn't pass, that increase would be $6 higher without this resolution passing. So the incremental cost of this resolution is lowering the premiums per month by $6. And so that's $72 per year.
Forgive me if I'm a little slow on this, but is there a direct correlation between passing this proposal and that $6 reduction?
This proposal is worth $6 essentially per month.
Okay.
By passing this proposal, the premiums that would be seen later this month, this would then be baked into the final assumptions for rates that we would bring, would be lower by $6. Another way to say it is when we bring the rates later, we'll be able to say this number right here on this page would have been $6 higher, but for the resolution, this resolution.
Thank you.
Other comments from the board? Yes, sir, John?
I'm curious, when you say $6 higher, is that $6 times the total number of PEB members or just the PEB members who would be using?
It's $6 in the premium that all Medicare retirees pay.
And how many Medicare retirees we're talking about?
In the Uniform Medical Plan, it's roughly 43,000 at this time.
So that's fairly significant, obviously.
Yes.
Thank you.
Thank you.
Other questions from the board?
And I apologize that couldn't be in writing. There's just, as you said, Elliot, there's a lot of moving parts, and I wanted to give us as much time to be able to have that assumption. I know that when you say a number, it's really important to be as accurate as possible, but we will, at the end of the month, when we bring rates, be able to show and say this number right here would have been $6 higher.
Well, that's a function of board discussions, so it makes what we're asking. Thank you, John. Worthwhile.
Any other comments?
Chair McDermott, there is Fred has raised his hand again. I don't know if you want to go back into additional comment.
Fred, you're on again, sir.
Thank you very much. I just wanted to make another couple quick remarks. There were only less than 200 people that bought what I consider as a Cadillac, almost ludicrous type of, headphone or hearing aid instruments that were $9,000 or more. So that's a rare exception, and certainly I think it shows a potential abuse of the system. I don't argue that, but you need to keep in perspective. It's a relatively small number of people that do that. There are still 2,505 people that would be adversely affected by this change. But that's all I wanted to cover. So and I appreciate the rate change, the information. That's valuable as well. So thank you very much.
Thank you, Fred. Since we gave the public another round, does the board have any additional comments? Hearing none, we'll go ahead and go into a roll call vote, starting with Harry.
I vote yes.
Kurt?
Yes.
Tom?
Yes.
Michaela?
Yes.
Elliot?
Yes.
And Lou, yes. Resolution PEB 2023-03 passes. Thank you, folks. Back to you.
Thanks, Chair McDermott, for
Is
passing
that-
it back.
This is back to me. Okay.
All right, so now that has passed, moving on to the next slide for some next steps. So we know this is going to be a change to UMP benefits. We want to make sure that members, providers, our third-party administrator regents is very aware of what we're changing. So we're going to be putting in a lot of effort to updating not only HCA's website and member communications, but as well as to Regents' website and communications, making sure all the providers are aware of this change as well as members. And then we'll also be updating Regents' its internal systems to show that benefit limit update. So moving on to the next slide, that is the end of the presentation. If there are any more questions.
I'm going to add another piece of information that I remember I said last at the subboard meeting, but didn't say here, and I want to make sure I acknowledge this here as well. We're going to make a change going in how we provide you some information going forward after this meeting. Board members will realize that as we send you the board briefing book the Friday before the board meeting week, we send the stakeholder feedback in two formats to you. We send both the raw emails that are received and then kind of an adjudication log, if you will, that copies over the substance of the email as well as how the agency has engaged and responded on it. In the future, going forward, in the presentations with resolutions, when we come back for the action meeting, we're going to include in the appendix that adjudication log so that the public can also see that type of information. This was actually a suggestion that Fred Yancey made. He asked about it right before the subboard meeting last week. We were kind of pretty far into production mode for this book to kind of pivot on it for this, but I wanted to acknowledge that nobody had ever asked that question, and we did that to help with transparency of the board, and it makes sense for public transparency as well as to what that stakeholder feedback was. So I really appreciate Fred bringing that up as an opportunity for increasing information again out to the public, and just wanted to acknowledge that we're going to be doing that going forward. And so I want to thank Fred for that, and not forget to say it here at PEB.
And I want to thank the board for that vote. I know it's always difficult when it feels like we're taking something away and trying to balance the benefit and the premiums and all the things that are in play. A lot of discussion on it, and I appreciate it. I mean, I know it's difficult, and I thought the way everyone handled it, the way they made the comments, the public comments, it's just appreciated because it is difficult. And there was a lot of internal debate on this issue, and it's never easy. So thank you.
And Chair McDermott, I want to acknowledge, and maybe Michael then come sit at the table. Michael Tunik's here.
Michael, you could have just come up. You don't have to sit in the wing. Katie, I think you're off the hook. Maybe
Sounds
she's
good.
already
Thank you very much. I think I might listen for a little while longer, but I'll just be in my unofficial capacity.
Okay. Michael, he's from the Attorney General's office and joining us. Welcome.
Thank you, Chair McDermott, and thank you, Katie Hatfield, for covering me.
Absolutely. Janice is going to go over, she's going to be staying with us to go over a proposed resolution regarding PEB UMP Consumer-Directed Health Benefit or Health Plans Minimum Deductible. No action scheduled for today. Her materials are behind tab number 5. Back to you.
Thank you. Good morning again, Chair McDermott and members of the board. For the record, my name is Janice McAlpin, and today I will be presenting on UMP Consumer Directed Health Plan IRS Minimum Deductible Adjustment. Going into the next slide, who wanted to cover some history and timing of the IRS changes. So historically, the IRS issues guidance for changes for the qualified high deductible health plans in each spring and summer. You can see the chart here covers the changes over the past decade or so, and we see a trend over the past few years that the amounts are changing almost yearly. PEB CDHP was $1,400 from the inception of that plan back in 2014, and the first time that we raised that was in 2023 up to $1,500 because we had set it at $1,400 above that minimum level, and now it has caught up to us. Back then in 2023 we had to raise it, and the IRS just issued guidance again for 2024, and that is being increased from $1,500 to $1,600 for self-only, and then the family is also going up from $3,000 to $3,200. And so you'll see also in the chart here on screen that the IRS guidance uses the terms self-only and family. And so we interpret those to mean self-only as our single subscribers and family is for all of our other tiers, which would be subscriber and spouse, state registered domestic partner, or subscriber and children, and subscriber and everybody else on the plan. So those will be the difference in the terms that you see on the chart in some of our communications that we put out, but wanted to call out that those amounts seem to be changing almost every year. So that brings us next to the next slide on what the proposed resolution for the board to consider is that instead of waiting to see what the IRS says every year, June is sort of late in terms for us of getting everything ready for open enrollment, because what now is also going to be having to happen is that regents will be having to send out new ID cards as well to members, because now, as of a couple years ago, there's a federal mandate that the deductibles and the out-of-pocket maximums have to be excuse me, on the front of the ID card. So that's also another thing to consider. And so we just wanted to be proactive and put forward this proposed resolution to maintain that minimum necessary qualified high deductible status. And so HCA wants to be prepared and not rush the board to call a special session. And that's not saying that we won't inform the board if anything changes, but you will no longer be required to vote on this call for action. So the proposed resolution for PEB 2023-04 would be for plan years beginning on or after January 1st, 2024, HCA shall set the annual deductible for UMP Consumer Directed Health Plan, CDHP, at the minimum annual deductible level established by the Internal Revenue Service, the IRS, to qualify the plan as a high deductible health plan without further action from this board.
The question about that. It seems like the underlying assumption is that it's going to go up every year. What if it goes down?
Chairman, we think we've crafted this resolution to be able to be flexible and use it in both ways. If the minimum went from $1,600 to $1,500, HCA shall set it at the minimum amount, it would be $1,500. So whatever is the actual floor that is set by the IRS, this resolution would say HCA is charged with implementing the floor, whether it goes up or down.
And that's sort of my comment. It's like, do we want it to go down? I'm just asking.
Yeah, I think the analysis here was in the very beginning, the plan was set at $1,400 as the deductible, which was higher than the floor that was set by the IRS. And the contribution, the HSA contribution that the state does was kind of coordinated with that deductible on some level. So, the purchasing power of that HSA contribution as the deductible goes up relatively goes down. So if the floor went down, it would help, right the ship on that and make those dollars more affordable. So I think it was intentional.
Okay. Yeah. I was just asking.
All right, so moving on to the next.
Actually,
more questions. Sorry.
Yeah, thank you, Sarah. I don't know that prepositional phrase, if that's the right term, I don't know if that is, without further action from this board is necessary. I think personally it's unnecessary, but kind of getting what Lou was saying, maybe it could be, I'd suggest it could say, unless otherwise resolved by this board. Just a thought.
Harry, we could definitely look at whether the value of that prepositional phrase at the end. I think the question, we were trying to help the timing issue, and if there's something that needs to be unless resolved. If there was a scenario, we're going to bring back once we have the notice at the next meeting to say this is what happened, and if there's if 2023-04 passed, we'd say per prior board action, we're moving and implementing this. We're going to provide the information of it. Some of it's just the timing though, and for rate development purposes, there could be this part where we get the notice and we're like, well, we need to bake that into the rates, but then we haven't talked about that part in executive session and how those also, it just kind of helps make it smoother into the rate setting process, because what the deductible is directly relates to the premium calculation as well. So we were just trying to streamline, knowing that whenever the IRS may not raise it every single year, and they may not raise it, it could go down, though I think most people would probably guess that the IRS will raise it more than lower it, but you never know. There's always, we could all have a happy day where the deductible drops by the IRS. As unlikely as that seems, it's always possible. But we were just looking at kind of streamline the process and not have to have the board vote on a new deductible possibly every year. And saying, there is a requirement in the state that the PEB program have a high deductible health plan that is HSA qualified. And that plan is we have always fulfilled that requirement with the Uniform Medical Plan, Consumer Directed Health Plan. And so it's just to make sure that we can tick and tie that together. Is that helpful, Harry?
Yeah, sure.
We will definitely look at that prepositional phrase because this is the feedback review process.
Sorry, red light.
Apologies that I missed some people. Okay, so moving on to the next steps. Like Dave said, we will incorporate any board feedback into the proposed resolution. We will be sending out the proposed resolution for stakeholder feedback by tomorrow, and we're going to ask for feedback to be sent back to us by June 19th so that I can incorporate that into what I'll be bringing forward to the board for action at the June 29th board meeting. All right, moving on to the next slide. That is the end. So if there are any more questions.
Any questions? All right. Janice, thank you. Next up, Shauna Lang, Portfolio Management and Monitoring Section Manager in the Employee and Retirees Benefits Division, is going to be providing us some information regarding the federal public health emergency ending and the effect it will have on the PEB program. Her presentation includes a proposed resolution on COVID-19 over-the-counter test coverage. No action is scheduled for today on this resolution. Her materials behind tab number 6. Shauna, good to see you.
Good to see you. Good afternoon, Chair McDermott and members of the board. My name is Shauna Lang, and I'm the Section Manager for Portfolio Management and Monitoring. I'll be giving an update on public health emergency unwind and presenting a proposed resolution for coverage of over-the-counter test kits. The federal public emergency coverage ended on May 11, 2023. PHE coverage included cost share waivers for COVID-19 diagnosis testing, lab and respiratory, and over-the-counter COVID test kits. PHE included coverage for antibody tests when covered when done inpatient setting, late onset, and outpatient for coverage, and outpatient for children with inflammatory syndrome. Under the Families First Coronavirus Response Act, there were certain requirements that must be met, such as the maintenance of eligibility prohibited states from terminating or reducing benefits for most Medicaid enrollees during the COVID-19 PHE, and kept coverage open regardless of income changes. This resulted in Washington Apple Health Medicaid enrollment increasing by 450,000 enrollees between March 2020 and April 2023. During this time, HCA also stopped collecting premiums for Children's Health Insurance Program and the Healthcare for Workers with Disabilities programs, and stopped verifying income eligible post-enrollment during that time.
As we move to the next slide, this is not unique to Washington State. This is happening across the country where the results of COVID and impacts on, the saying is if you've seen one Medicaid program, you've seen one Medicaid program. This is something that almost all Medicaid programs have in common, that there was this pause on redeterminations and eligibility, expanded Medicaid population rolls across the states, and now with the unwind, as Shauna goes into the next slide, is resulting in redeterminations where quite a few individuals across the country will lose Medicaid coverage. And so, Shauna, take us into that part of the unwind.
Right. HCA is actively working on the requirements for the Consolidated Appropriations Act to draw down enhanced funding from the federal government and continue receiving through the unwind period. The defined unwind transition period is between April 1st, 2023 and December 31st, 2023. There are conditional requirements to draw down per the enhanced federal medical assistance percentage. Some of these conditions include the certain redetermination requirements in accordance with the Social Security Act states that must make good faith efforts to have an up-to-date contact information for clients, and between April 1st, 2023 and June 30th, 2024 states that must report certain data requirements, and data will be made publicly available. States may face penalties and corrective action if they fail to meet requirements. HCA also launched a comprehensive outreach campaign to help individuals transition coverage, as redeterminations will happen over the course. These communications include weekly Gov deliveries, partnering with state agencies, social media campaigns, postcards, print materials, training webinars, and an ambassador program.
So also on the slide, I want to put a fine point on that second purple sub-bullet. All 2.3 million Apple Health enrollees will be renewed over the next 12 months. 2.3 million redeterminations by this agency over the next 12 months. It's 1 in 3 Washingtonians practically that there will be some sort of engagement with by this agency in our state. And one of the things we wanted to highlight for this board is impacts overall in the insurance market. When there will be some individuals, an unknown number of individuals who will not qualify for Medicaid after this redetermination. And so some of them may become dependents in the PEB and SEB program. Some of them might go to other employer-sponsored insurance. Some of them may qualify for a tax subsidy through the exchange for exchange coverage. And some of them also may end up uninsured. So there's going to be this movement of a large segment of our citizenry, a couple of 100,000 individuals is the projection, into other parts of the market or potentially into the uninsured setting. So we could see increased covered lives in our program. So we're fortunate here that our agency has both Apple Health and PEB and SEB in the same agency and has very close connections with the Health Benefit Exchange, which was born from this agency in its original inception. It's literally across the street. So we have strong connections to be able to help provide communications about paths that individuals who receive a redetermination that they're no longer eligible for Apple Health, what those options may be. And that's where, our program will have work with our agency has work both within and across the PEB, SEB, and Medicaid program. So just wanted to highlight that significant body of work that this agency is doing and its impact on insurance in our state. John?
Yes, has this policy change, both in terms of new lives and staff support, been incorporated into the approved budget for this coming year?
Yes.
Yes,
Yes, the Forecast Council has estimated the number of people who will come off the rolls, and that is how our budget is set. So it's been incorporated into the budget with assumptions. Are they going to hit it right on? No. They're going to be cleaning up during the supplemental.
Thanks, Luke.
Yep.
Next slide, please. Next slide, please. All right. This slide shares more information about Apple Health resources and the impact to PHE and includes information on HCA's response, FAQs, impacts to Apple Health data, and contact information. Premera's coverage for COVID test kits. So we're moving from Medicaid into PEB at this point. So we're going to go over what changed in Premera, Kaiser, and UMP on May 11th when PHA ended. So for Premera's coverage for COVID treatment, lab tests will all now be paid at the standard plan benefit. Over-counter test kits will not be covered, and vaccines will be covered under the preventive benefit. So under the Kaiser program, the Kaiser coverage for treatment lab tests will also be paid at the standard plan benefits. Over-the-counter test kits will not be covered, and vaccines will be covered under the preventive benefit. As of May 11th, UMP's coverage for COVID treatment lab tests will be paid at the standard plan benefit. Over-the-counter test kits will not be covered, and vaccines will be covered under the preventive benefit.
So to summarize, Shauna, I think essentially said Premera, Kaiser, and UMP all had the same shifts on all these various ways that payment is occurring and what is and isn't covered.
This moves UMP towards the benefits that are in the resolution for July 1st for over-the-counter COVID test kits. During PHE, over-the-counter COVID test kits were required to be covered at 8 tests per member per month with a maximum reimbursement of $12 per kit. The biannual operating budget passed by the legislature provides coverage for 2 over-the-counter test kits per member per month without cost share up to $12 per kit beginning July 1st, 2023 for the UMP plans. This then leads us into the proposed budget or proposed resolution, and it reads as follows. Beginning July 1st, 2023, all uniform medical plans will be covered for 2 over-the-counter COVID-19 diagnostic per member per month, up to $12 per test kit without member cost share. If the Internal Revenue Service issues future guidance that requires deductible to be met prior to planned payment, over-the-counter COVID-19 diagnostic tests in high deductible health plans, the UMP high deductible plan shall be amended to comply with IRS guidelines without further action from this board.
I'll add some context on that second paragraph. There are some consultants that are opining that the IRS may make some changes related to how over-the-counter tests are treated. That's why that phrase is there. Right now, they have not issued any such guidance, but we're concerned that there could be something that is changed after the board season, but before January of 2024, that would require implementation. And in order to meet state law requirements of offering an HSA qualified plan, we would have to implement them. So we just kind of wanted to start raising awareness that there is something that could be changing in that area. It's not known whether it would or wouldn't, but again, wanted to try to be transparent about the potential changes and the requirement that our agency has to maintain a federal qualified HSA plan. So, walking through time, we had COVID tests covered, 10 of them per member per month with no cost share up until May 11th. Then from May 12th until at least June 30th, there is no coverage for over-the-counter tests. And then this kicks in as of July 1st of this year. It's unusual to have a type of benefit change like this, but the way our plan year doesn't align with our fiscal years, the budget that was passed and signed by the governor last month did include within the funding assumptions coverage of up to 2 tests. And so we're bringing that to finalize that implementation piece with the board on the last stages of the authorizing environment. This 2 over-the-counter test is not part of the fully insured plans. So it is not anticipated to change for Kaiser or Premera. It is only for the Uniform Medical Plan.
Are there any questions?
Any questions for Shauna? All right, seeing none. Thank you, Shauna.
Thank you.
Why don't we go ahead and take a break? It's 10 o'clock. Let's call it 10:10. Thank you, folks. Okay. Could be. All right, folks, I think we're going to get rolling again. And Monica, have you joined us? Monica, are you on mute? I don't think Monica has joined us, or maybe a member of the public. All right. Welcome back, everybody. Our next item, Molly Christie, our Fiscal Information and Data Analyst in the Financial Services Division, is going to share some information on the multi-state analysis regarding retiree health plan offerings for materials behind tab number 7. Molly, welcome.
Thank you, Chair McDermott, members of the board. As Chair McDermott mentioned, I'm going to be presenting an analysis that we conducted examining the ways that states provide health insurance to retirees who are enrolled in Medicare, with a particular focus on other states that have plans that coordinate benefits with Medicare, similar to UMP. So we received assistance on this analysis from our contracted actuaries at Milliman. They have a proprietary data library with information on state-offered health plans in all 50 states. So this was a great resource for us for this project. And our primary research question was, how do other states provide health benefits to retirees who are enrolled in Medicare, including the types of plans that are offered, the benefits that are covered, the premiums, and then whether those states provide subsidies to help reduce the cost of premiums for retirees. And I'll walk through the detailed results of this analysis. That's the intent of this presentation. But just at a very high level, we found that there is immense variability in whether and how states supplement Medicare for retirees.
I have just one quick question.
Of course.
So when you say retirees, are we talking about just state employee retirees, or are we talking about everybody?
So we're talking about state retirees and sometimes also school retirees. It depends on the state. Not everyone, of course, does things the way we do. So we have our school retirees also enter the PEB program if they elect that coverage. Some states do that as well. Other states have local bargaining. So it really depends. But we're definitely talking about state retirees, and sometimes we're also talking about school retirees. Yeah, of course. So at a high level, there is immense variability. There is not one size fits all approach. But we did learn, interestingly, that Washington is the only state that offers every plan type that we observed. So we are very unique in several ways, and I will touch on those ways during the presentation. Next slide. So there are specific types of plans that employers may offer to retirees who are enrolled in Medicare. I've separated these here by medical and pharmacy, and these are likely all familiar to the board because these are all plan types that we offer. For medical benefits, states may offer plans that coordinate coverage with original Medicare. We typically talk about this as coordination of benefits, or COB, but what we learned through this project, through this analysis, is that there are several ways that states can create provisions for coordination with Medicare. One of them is COB, and there are a few other types as well that I'll talk about. So I'm going to be talking about coordination plans generally, and then I will go into COB plans specifically. As a reminder, original Medicare covers Medicare Parts A and B. So Part A is hospital inpatient, Part B is outpatient doctor's visits. And these plans often, these coordination plans often, but not always, mirror coverage for employees. So similar to UMP, where we have UMP Classic for employees, and then we also offer that to Medicare retirees. A lot of other states that have coordination plans do something similar. But in the case of Medicare being a primary payer, these plans pay secondary. Medicare Advantage plans just briefly cover all services under Parts A and B of Medicare. And oftentimes they also have a pharmacy component through Medicare Part D. There are many types of Medicare supplement plans, all letters of the alphabet essentially. But the function of these is that they cover some degree of member cost sharing under original Medicare, so that 20% that Medicare doesn't cover. And then states may offer medical plans with or without prescription drug coverage. This might be through Medicare Part D, as I mentioned. This is the standard benefit that is defined by CMS, the Centers for Medicare and Medicaid Services, and Part D plans are offered through insurance companies. They can be standalone or integrated with medical coverage. They can also be self-insured or fully insured. So there's a lot of variation there. And then states can alternatively provide pharmacy coverage that is not through Part D. So this is what I would call like standard pharmacy coverage. If the coverage is at least as rich as Part D, then it's considered creditable and it may be eligible for a federal subsidy. So we do receive a federal subsidy for our prescription drug coverage under UMP. It's called the RDS, the Retiree Drug Subsidy. Next slide. So benefit provisions vary widely according to a lot of factors, such as whether a plan has a narrow or broad network, an HMO versus a PPO, the cost share structure, so deductibles, out-of-pocket limits, visit limits, and then the services that are covered, the actual covered benefits. And as we'll see in the next slide, some states do not offer any plans to public retirees. Additionally, there is wide variation in the amount of premium charged to retirees. So throughout this presentation, I primarily am going to be discussing premium in terms of total premium. That means the entire monthly amount charged by an insurance carrier or set by an employer if it's a self-insured plan to cover members. So this is what we call the bid rate when we're talking about rates for PEB.
So Molly, just for clarification,
Yeah.
that would include the employer or the state's share and?
Exactly.
Okay,
Yeah. So then you also, when we're talking about total premium, that's any state share. If there is a subsidy, it would include the value of the subsidy. If there's a retiree premium, sometimes the retiree premium is the same as the total premium if there's no subsidy, and sometimes the retiree premium is lower if there is a subsidy.
And I think Tom has a question or comment.
Yeah.
Thank you. HMO, Health Maintenance Organization, so in some states, you have to sign up with Secure Horizons is a HMO. So you would have to sign up with them, whereas in our state, because we have a PPO, preferred provider, but are there both in some states? Is that, or is it
Yeah.
just all over the place?
It depends on the carriers that are available. We do have HMO products for our Medicare retirees. We have the Kaiser Northwest and Kaiser Washington Medicare Advantage plans. So those are HMOs. In Medicare Advantage, you can have plans that have a narrow network or plans that have a broad network. So our broad network Medicare Advantage plan is the United plan. And then UMP, of course, is a PPO, but it is not a Medicare Advantage plan. So it really just depends on what's available in that state and how that state chooses to contract with those entities.
Thank you.
So as I mentioned, there is a lot of variation in the amount of premium charged to retirees. If state subsidies are available, they can take the form of a fixed dollar or fixed percentage of total premium, regardless of what plan a member selects. So that is what we have in Washington that's set by the legislature. Our explicit subsidy is a fixed subsidy. These can also vary based on the cost of the plan as well, or they can vary based on a retiree's years of service, other factors. There's a lot of different ways that employers can do this if they are choosing to offer a subsidy. I will say that what we found is the fixed contribution approach is the most common. And again, this is what we do in Washington. We have the 50% of premium or that cap of $183, whichever is less. Next slide. So this is our beautiful map. It's very colorful, as I mentioned. There's a lot of variation. We are the only pink state, yes. So this map shows the distribution of Medicare retiree plan types by state. The key on the left describes the plan types, and it identifies the number of states with that plan or combination of plans. This was very hard to kind of categorize. So there are a lot of different colors here, a lot of different categories on that legend, but I'll walk through what you see. So coordination, so states that offer coordination only plans, there are 6 of them, and Washington is one of them. There are 2 states that offer coordination plans and Medicare supplement plans. There are 15 states that only offer Medicare Advantage plans. There are 3 states that offer Medicare Advantage and coordination plans. There is 1 state, the state of Washington, that offers Medicare Advantage, coordination, and Medicare supplement. There are 10 states that offer Medicare Advantage and Medicare supplement. There are 7 states that offer only Medicare supplement, and then there are 6 states that do not offer any plans. So there is a lot of variability, but there are some plan offerings that are more common than others. 29 states have Medicare Advantage plans. 20 states have Medicare supplement plans, and then 12 states have coordination plans. A quick note of the 6 states that do not offer plans, 3 of those do offer a subsidy for retirees. It's through a health reimbursement account, an HRA. It's kind of similar to VEBA, and retirees can use that subsidy to go purchase their own coverage on the individual market.
But the other 3?
The other 3, it's nada. Yeah.
No subsidy, no plan.
No subsidy, no plan, correct.
And just if you were writing down Molly's numbers of 29, 20, and 12, that's more than 50 because, as you can see, there are some states that offer both.
Yeah.
So just wanted to put a fine point if somebody was trying to add and going, you've hit more than 50.
Thank you, I appreciate that.
But the legend on the left on this slide does add up to 50. Should. Elliot has a question.
Yep.
Just a quick question. What is Rhode Island? I could not make it out last night.
Rhode Island does not, if I remember correctly, they don't offer plans.
Thank you.
They're red. They're one of the 6.
I couldn't tell if they were orange or red. Maybe it's my age.
It's not. It's really not. My toddler would call both the orange and the red orange, but that's also because that's his favorite color. Too. So, you know.
The senior citizen would also.
I think it's an orangey red. Any other questions on the map before I move to the next one? No? Okay. Next slide. So for states that offer retiree plans, those 44 states that have plans, the average number of plans is approximately 4, but it ranges from 1 to 20. If you want to orient Washington in there, we have about 7 plans. I did exclude the Kaiser COB plan and the Plan F from that because the Plan F is grandfathered only and the COB plan for Kaiser is kind of working in the background. So we're near the average, but we are above the average. We found that more plan choices seems to be correlated with either a larger retiree population, so you have states like New York, California, like these massive states, or regional availability of plans. There are some states that only have plans that cover a very small region, and so they've decided to have a lot of different plan choices so that members everywhere in the state have coverage. Many states choose to offer plans that are fully insured. Medicare Advantage plans are always fully insured, but Medicare supplement plans can be either self-insured or fully insured. 20 states have only fully insured plans, so again, either Medicare Advantage or Medicare supplement or both. And 11 states have both fully insured and self-insured plans. There are 13 states that have only self-insured plans through either coordination with Medicare or as a Medicare supplement, and then again, 6 states offer no plans. Okay, next slide.
You know, Molly, this is fortuitous. I was just thinking about this. I learned yesterday because Sue last year highlighted that I'm in a fellowship that involves other state leaders. And yesterday I learned that there's going to be a 7th state that doesn't offer retiree coverage. The state of North Carolina closed future retiree health insurance for their public sector employees. I'm not sure the effective date of that, but it is a recent decision in the North Carolina legislature budgetary process that they are maintaining coverage for the existing population, but future employees or retirees will not have an option. I'm not clear yet if there is a subsidy or not, like if they join the 3 that have a subsidy or the 3 that don't, but it is another development that I just happened to learn about yesterday from a colleague in North Carolina. And so timely for this presentation to highlight just another change in this area.
Hopefully the legislature didn't exempt themselves from that policy.
Lou, can I ask a quick question? Because I didn't find it in here. So I know that there's at least 3 states that provide nothing. Do we know of the other 47 that provide no contribution?
So I don't, I did a very high level count of the states that have any sort of subsidy, any degree of subsidy, and it's about 2/3. I forget the actual number. So it's still the majority of states that it actually includes states that that don't have plans to those 3 states that have a subsidy.
The reason I asked is I used to live in a state that provides several plans, but no contribution.
Mm-hmm.
So, I mean, just because you got a plan doesn't mean, they're better than us by any stretch.
Of course, yeah, and in one of my subsequent slides, we find that that it seems to be relatively uncommon. Only 2 states of the 6 that have coordination of benefits, similar to UMP, offer a contribution, and Washington is one of them. So looking at total premium costs, again, when I say total premium, I mean including any employer contribution, if there is an employer contribution. We find, generally speaking, that Medicare Advantage plans have the lowest premiums, Medicare supplement plans are in the middle, and then coordination plans have the highest premium. So I'll walk through these. For Medicare Advantage, the median total premium is around $200. The minimum is $0. I'm sure you've all heard of Medicare Advantage plans that have $0 premiums. And then the maximum is $625. For Medicare Supplement, the median is $411, the minimum is $96, and the maximum is $660. And then for coordination plans, the median is $462, the minimum is $213, and the maximum is $699. And this
Molly,
is
is
based on
that
2023.
a single subscriber or single spouse?
Good question. This is a single subscriber.
Got it.
And that $213, you see a little asterisk there. That plan is in Mississippi and it does not include prescription drug coverage. So that kind of does lead me into the comment that we always have, the caveat that we always have, which is it's super hard to do these types of comparisons. And I'm just presenting static figures on a screen, but these costs don't necessarily reflect the richness of benefits. This tells us, it doesn't necessarily tell us anything sometimes about what that plan covers. And, there are so many factors that go into premium costs. You're talking about federal subsidies, right? Because some of these plans have a Part D coverage. Some of them, Medicare Advantage plans have subsidies through risk adjustment. From CMS, there's the relative cost of healthcare across states, negotiated allowed amounts, so how those employers, how the states negotiate rates with the carriers, population demographics, all of these things. It's very, very complex. As you know, we present rates to you each year, and we always have a lot to say about it and a lot of discussion, so wanted to make that point. Next slide. So these are the 12 states, including Washington, that have at least one plan that coordinates benefits with Medicare. And all of these coordination plans are self-insured plans. And these states are Alaska, Florida, Iowa, Maryland, Mississippi, Montana, New York, North Carolina, but not anymore, I guess, Vermont, Virginia, Washington, and Wyoming. So it's kind of an interesting group. It was surprising to me. It's not necessarily all the states that I would expect to be on the list. Next slide. So as I mentioned before, there are several ways that plans can coordinate coverage with Medicare as the primary payer. Under a carve-out plan, the plan calculates what it would pay toward the claim, the normal benefit, and then it reduces its payment by the amount that Medicare pays. Under maintenance of benefits, the plan subtracts Medicare payments from the total allowed amount, and then it applies the plan's benefit limits and cost sharing to whatever amount remains. And then under coordination of benefits, which includes UMP, Classic Medicare, Medicare pays first, and then the plan pays all amounts not covered by Medicare up to what would be paid without Medicare. The next slide walks through with some numbers, so it's easier to understand. But again, as you saw on the previous slide, those 12 states offer plans that coordinate with Medicare, so they offer carve-out, maintenance of benefits, or coordination of benefits, but only 6 plans offer specifically coordination of benefits as it's defined here. And those states are Florida, Mississippi, Montana, Virginia, Washington, and Wyoming.
So I'm just going to highlight, you can see the funneling effect that gets to the uniqueness and the fact then that Washington has a lot of unique aspects. I remember, I think it was 2 months ago, Chair Birch kind of mentioned we were going to be bringing this presentation and she said the number 10. And so it was like, well, 10, but, because there's lots of nuance, 10 that have some sort of coordination. Ended up it was actually 10 plus, well, it was 10 and Washington was 11, but it was really 12 in the end. But then as you narrow and look at, well, what type of coordination plan? It's really more like 6. But then Molly's already previewed, and she said multiple times, Mississippi is one of those 6, but it doesn't have prescription drug coverage. So is that really comparable in this context? So the funnel gets really small here, just to kind of put a finer point on that.
Yeah, thank you. So next slide. So here's the illustration of how these coordination plans work. This is a theoretical scenario where a provider bills $200 for a service. And in each case, the plan allowed amount, which is also the Medicare allowed amount, is $100. And the plan has a 15% member coinsurance and an 85% plan paid amount. So under a normal benefit where the plan is primary, it would pick up $85 of the $100. But because Medicare is primary and these are coordination plans with Medicare, Medicare covers 80% or $80 out of the $100. So then moving to carve out on the left, the plan calculates what it would pay toward the claim, which is $85, and then it reduces its payment by the amount that Medicare pays, which is $80. So the plan pays $5, and then the member, the retiree, pays the remaining $15. So really under a carve-out design, the plan is lowering its costs because Medicare is paying primary. The member is still paying the same 15% coinsurance they would always pay. So, you know, these plans are likely probably able to be to have lower premiums than a coordination of benefits plan, which I will move into in a moment. Under a maintenance of benefits design, the plan subtracts Medicare payments from the total allowed amount, so $100 minus $80, and then it applies the plan's benefit limits and cost sharing to whatever amount remains. So in this case, 100 minus 80 is $20. The plan covers 85% of $20 or $17, and then the retiree pays the remaining $3 as their cost share. Under coordination of benefits, Medicare pays first, again, $80, and then you have a remaining $20. The plan picks up the full $20 and the retiree pays nothing. Any questions about these different types of coordination plans? Okay, next slide. So we wanted to take an even closer look at the states that have COB plans. Again, these are states where, for the most part, services that are covered by Medicare are paid 100% between Medicare and the plan, and members pay $0 out of pocket for those Medicare covered services. And what you'll see here as you walk through each of these categories is that UMP is relatively unique in the richness of our covered benefits. So for prescription drugs, and there's no coordination of benefits for prescription drugs. Prescription drugs are either covered fully by the plan as a non-Part D standard drug benefit, or they are a Part D benefit, which is separate from medical. So 5 out of 6 states offer prescription drug coverage. 3 of these states have Part D, and then 2 have standard or non-Part D coverage. One of those states is Washington. Looking at vision, only Washington includes routine vision and hardware benefits integrated into the medical plan. Some of these states do offer it separately as a buy-up, but we're the only state that includes it in our premium in our medical coverage. 2 states, Virginia and Washington, have coverage for hearing aids. Original Medicare does not cover hearing aids, so this is a benefit enhancement. Virginia has a $40 copay for a hearing test every 2 years, and then a $1,200 limit for hearing aids and supplies every 2 years. And then, of course, you know that Washington currently, no longer has an unlimited benefit, so the board passed the resolution today where we have that $3,000 limit per year every 36 months.
I think John has a question or comment.
Yeah.
Molly, which pharmacy plan would be considered more generous, the Part D or the standard plan?
That's a tough question. It depends on the plan and the plan design. So
let's take our standard plan.
Yeah.
Versus a Part D plan.
I would say if you take our UMP pharmacy plan and you compared it to your average Part D plan on the individual market, our plan would likely have richer benefits in terms of member cost share at the pharmacy. I would say if you compared our pharmacy benefit to the United Part D pharmacy benefit, they're very comparable in a lot of ways. And because we built the United benefit based on UMP, there are differences sometimes in the formulary because Part D formularies are regulated by CMS. So there are drugs that are required to be covered that sometimes commercial plans that are not Part D won't cover, and CMS says Part D plans have to cover. And then sometimes it's the other way around where, you know, a Part D formulary can choose to cover a generic and not a brand drug, whereas a standard prescription benefit might choose to offer the brand drug as well. It really depends. But yeah, I think, you know, you'd have to take a really deep dive and look at the formularies, look at the cost share, all of those things when you're comparing 2 specific plans.
And maybe I can address this to David, but
Yeah.
have you had any complaints from participants that their medication that they're looking for is not in our formulary, but is in a Part D formulary?
I'm going to have Ellen think about that question because she's going to come up next and she would have probably the best insights as to the types of things. So Ellen, you're on deck for that one as part of follow-up in a few minutes. I see Ellie has a question, but I want to have Molly, I want to have you talk a little bit about the relative subsidies. So you've talked about the benefit, but the other impact is what qualifies for what type of subsidies. And there's definitely a different qualification for federal subsidies between a Part D formulary and a standard. So you can talk a little bit about that?
Yeah, definitely. So,
Actually, Elliot's got a
let's take Elliot's question first.
It's pretty quick. I think the cost of some of these drugs doesn't always depend on whether it's Part D or UMP. It also, sadly, I've had experience with this, it depends what drug you're talking about too.
Absolutely, yeah. So to Dave's point, there are different funding mechanisms for a standard pharmacy benefit versus Part D. As I mentioned earlier, so our pharmacy benefit for UMP Classic Medicare does receive a federal subsidy. It's called the Retiree Drug Subsidy. And historically, CMS created the subsidy to incentivize employer plans to continue offering prescription drug coverage when Part D came out. Fewer and fewer states are doing that because it's just, pharmacy is so expensive. But we receive the subsidy, it goes to the state general fund, so it is not built back into our premiums. The Part D plans, however, receive direct subsidies from CMS. It's essentially to cover a percentage of the cost of drugs. And then they're also receiving manufacturer discounts and several other pieces that help build up their revenue so that they can condense their premiums and charge less to the members. So you'll see, I think, in general, looking back to 2006, I remember looking at this at one point, premiums for Part D plans on the individual market have been pretty stable. They've hovered around like $30 and they haven't swung too significantly, which is surprising for pharmacy because, you know, we're always talking about pharmacy trend and it's like so unpredictable and it's so high. And that's really a function of those subsidies. But we are going to be looking at some changes in the future under the Inflation Reduction Act, which is targeting Part D specifically. So there might be some impacts on the cost of those plans moving forward, but there are a lot of advantages because the feds are trying to help reduce member out-of-pocket costs so that prescription drugs are not so expensive when you go to the pharmacy to receive them.
And Molly, back to John's original comment, a lot of it just comes down to the individual and their circumstances, the medications they're on, the treatment. I mean, obviously for a young person who's bulletproof and healthy, a high deductible plan's pretty awesome. You got a low monthly premium, you never go to the doctor, it's great. So really coming back down to the individual.
Yeah, absolutely.
Yeah. The other piece about subsidies, because qualification for subsidies varies a lot, but the value of those subsidies also varies a lot. And I don't want people to walk away and go, oh, with the current standard formulary, that RDS, retiree drug subsidy, that's a federal subsidy, and we get a federal subsidy. That range of that federal subsidy is usually in the $20 to $24 million range. The value, that is small. And the state spends almost $200 million in creditable drug coverage to qualify for $20 to $25 million. And you did hear me say that correctly. The state spends annually almost $200 million, and that cost gets higher year over year to receive $20 to $24 million. And as Molly said, that 20 to 24 goes directly into the general fund. It doesn't go directly invested back into premiums in a direct account manner. Whereas the other subsidies that the other plans receive through CMS that are risk adjusted are much more valuable and are much more significant investment. And we've talked before, last board season and this board season and possibly 2 board seasons ago, about that is rooted in the Social Security Act passed by Congress, setting up the framework for who qualifies and who doesn't. And that CMS would need to have a change, there'd need to be a change in federal law. We've been working on and are near finalizing a letter to our congressional delegation that describes kind of where we see that problem and the loggerheads that have come up in our state because of it. But I just need to put I think it's really important to remember that the value of those subsidies that like a Part D receives are much more valuable and have much more impact on premiums and overall plan costs than the RDS that a standard pharmacy creditable drug coverage receives.
Yeah,
and as
it's
Molly,
effectively more than 75% of the cost of the plan is gained back in revenue from subsidies and from discounts. Thank you. So the last column here is the state premium contribution. As you see, 2 states out of these 6 states that have COB plans have a state contribution, Washington and Wyoming. And then, sorry, I do have another point on here. It's our typical caveat. I tried really hard to look at these states and see if I could compare additional benefits. And it's reading COCs. It's getting into specific plan provisions and how these plans administer their benefits. And it's just too challenging. So, I think that these benefits are really the ones that are helpful to compare, because generally speaking, for a COB plan, if it's covered by Medicare, the plan is paying the additional cost. And so there's not a lot of variation there, but when you get into any sort of supplemental benefit, it becomes very complicated. Next slide. So this chart shows the 2023 premiums for the 6 states that offer Medicare COB plans, and it's broken down by retiree premium in this lighter blue, and then the state contribution in darker blue where it's applicable. This is by plan and by state. So you see the states at the very bottom, and then the plan names are closer to the bars. And the total premiums range from $213 to $699. $213 again is the lowest. It's Mississippi, and there's no prescription drug coverage for that plan. There are so many variables. I've mentioned this already that influence the rates. So we have to be careful about making assumptions based on the premiums presented here. Some examples are like differences in covered benefits, as I mentioned again, the cost of medical services in a state, the demographic characteristics and population size, how the state does risk pooling. So who's included in that rate. It all is a very complex calculation. So this gives us a little bit of insight, but it doesn't give us the full picture.
And Molly, these are some of the things I take away when I look at this slide as I try to kind of digest this information. One might look at it and go, okay, so UMP is on the higher end on its bid rate. Molly has given some information along this presentation that helps give some of the context to that. On the prior slide, we have a credible drug coverage, which in some ways may be richer than a Part D coverage. Vision and hearing aids are atypical benefits that are covered that are also contributing to the total bid rate. We know and talked several times that Mississippi is an outlier for a COB plan and that it doesn't have prescription drug coverage. So we have prescription drug coverage and those other benefits. And then I turn and look at Wyoming and I'm like, okay, well, they have similar kind of cost, but importantly, and Molly said she couldn't do an analysis of deductible across all the plans, but Wyoming names their plan Cigna $2,000 deductible. So right there, they include the deductible in the name, and you can see and compare in UMP Classic Medicare, yeah, we might have similar bid rates and even similar state subsidies, but our deductible is much lower than $2,000, $4,000, or $900. So the point I take away from a lot of this presentation is the benefit that we have here in Washington on a COB plan is unique, and that it is also a rich benefit compared to what other states are providing. And with a rich benefit, there are increased costs of it.
And for the deductible, most members in UMP Classic Medicare do have their deductible reimbursed through the COB Savings Bank, which is a unique feature of our plan as well. We were not able to identify other states that had that.
And I want to be clear, I'm not saying that rich is bad. It's just a factual statement about the relative cost. It is a richer benefit than many other states, and that helps explain why the cost is higher than many other states. So I don't want anyone to walk away thinking that I or the program staff think that a rich benefit is a bad thing. That is absolutely not what's being said. It's the factual part of explaining why we see the rates we see compared to other states.
Okay, next slide. This is my final slide. I think I've used the term variability a lot today, but that's the theme, right? There is extensive variability in state-sponsored retiree health coverage when it is offered. Most states do offer at least one health plan for retirees who are enrolled in Medicare, but only Washington offers all plan types. Washington is also one of only 6 states that has a coordination of benefits plan. There's a broad range in cost shares and supplemental benefits. Compared to other states with COB plans, UMP has very rich benefits, and as Dave mentioned, this does also contribute to our higher premiums. And then most states, about 2/3 of states, have some subsidy for retiree premiums, but only 2 of the 6 states that have COB offer a subsidy, and Washington is one of those states. So that is the entirety of my presentation, and if there are more questions now or later, please feel free to reach out to me.
Thank you, Molly. That was one of the most comprehensive reviews of the national scene that I've seen in a long time. That's,
Great job.
Yeah, that was
pretty
outstanding.
awesome. Do we have additional questions or comments from the group?
Yeah, I was just going to say before you said, just outstanding, just incredibly good.
Awesome. Thank you so much. Really appreciate it.
Yeah.
Next up, Ellen Wolfhagen is Senior Account Manager for PERB Division, is going to provide some updates on the ongoing retiree engagement work. The materials behind tab number 8. Ellen, welcome.
Thank you, Chair McDermott, and it's nice to be here. Hello, board members. So first, I'd like to address John's question about the differences, and I don't have specific drug information, John, but I'd be happy to research that and get back to you on it.
Thank you.
But I'd like to just give a brief overview of some of the comparisons between the UMP formulary and, for example, our Medicare Advantage, including prescription drug plans, which have a Part D plan involved. There are thousands of drugs on each formulary. So there are differences, potentially, in formulation. So one plan may cover, for example, a cream formulation or a liquid formulation, a skin topical formulation, and another plan may not cover that formulation, but they do cover the drug. So it's important to understand that it's not just drug names that are important or generic names that are important, but also the formulation. What is the delivery method for that drug? There are differences in preferred insulins. There are different brand names associated with insulin. There are different time release attributes associated. For diabetes, blood monitor checks, glucose monitor checks have different brand names associated with each plan. They are functionally equivalent, but they may be different because it's different brand names. And then finally, there may be differences in the tier. So as you know, UMP has a value tier, which doesn't exist in Part D plans. So where the drug falls in terms of the tier and the cost share that's applicable may be very different. But again, if you would like, I will go back and look at specific drugs. So today's presentation really is a focus on the retiree engagement that we've been doing. Next slide, please. I'm going to talk about the listening sessions and the public forums that we've had and some of the communication pieces that we are involved in. Next slide, please. So as of May 31st, we had 24 sessions, including 4 in-person sessions. These are the listening sessions. The in-person were held in Tumwater, Cheney, Yakima, and Bothell. We had a total of 268 registrants and 193 participants. I do have an asterisk to add to that. We actually had 200. We've had comments that have been submitted that people didn't necessarily show up at the listening session but submitted comments. And there were some people who we didn't capture immediately. And I believe it's a typo on my part. I think it should have been 198 participants. So the initial themes that we heard were keep UMP Classic Medicare. And whether it was said specifically as that or it was worded in terms of PEB should always have an option that coordinates with Original Medicare. So I would combine those two things. People obviously mentioned that costs are too high. Specifically, they called out not only the premiums for UMP, but the costs of UHC pharmacy. So I want to just spend a minute clarifying that or expounding on that. In 2023, the United MAPD plans changed the way that the Part D benefit was applied in both the PEB balance plan and the PEB complete plan. So we went from a co-share, which is a percentage, to a flat copay. What that meant was that for some people on generic drugs, the generic tier is a $5 copay. For some people, that $5 was an increase over what they used to pay. Most of the comments that we heard were, yes, it's much more money than it used to be. You know, I used to pay 72 cents, right? So it's a huge increase percentage-wise. But compared to the premiums, the cap at $5 a month is so much less that I can readily afford this. So I just wanted to create some context around this. I also want to note that for the flat copay, that reduced the cost for many members at the higher tiers if they were on either preferred brand name or specialty drugs.
And I just want to bring back that it was last board season when this change was proposed, and part of the conversation at that time was that there were members who were considering switching plans, but they were finding it challenging to understand in any sort of predictable manner what their costs would be. And that is, you know, the tension that exists between co-insurance and copay models, percentages versus flat amounts. And so there was a conversation at the board and an authorization to make that change in response to that customer kind of member feedback about having more predictable out-of-pocket. And so just like, every change, there are, our population is so large that there are going to be challenges for some parts of our population. So now we're hearing the other side of that equation about some of those cost increases, especially in those generic spaces. But I just wanted to remind that the transition from co-insurance to co-payment was because there was this concern from retirees that were considering changing, but were very wary about moving to a co-insurance model, which does not inherently have as predictable an outcome. Elliot, I saw your mic come on.
Yes, I wanted to know, do you think, and if you can't answer this, believe me, I understand, was this change a result of the acquisition of Optum by UHC?
I don't believe so, because Optum and UHC had that relationship preceding when the change was made. It was really an analysis of the concerns that people had in trying to figure out the difference in the formularies, and a flat copay is a more preferred model, if you will. It is something that on the commercial market is very favorable. Finally, I do want to note for the board that the listening sessions were highly appreciated. Every single session, people came back and said, thank you so much for the opportunity. We really appreciate the chance to come and talk face-to-face to people, face-to-face on video, to people at HCA. And especially because of the way that the listening sessions were held, people really appreciated hearing from other members. So what we heard, and especially at the in-person sessions, was a lot of members educating members, so that they would turn to somebody else and say, no, the plan works differently than you think. And that was an interesting finding for us, that there are misconceptions about how the plans work. People have different levels of education and familiarity with how the plans work. But everybody appreciated hearing about other plan options, and for good and bad. They wanted to know what worked well and what didn't work as well.
And I'll just add for the listening sessions, the way they were structured and how we worked with the coalition on trying to have the recruitment of members, there was an aspirational goal for each listening session to generally have representation that was roughly proportional to the enrollment mix in our plans, meaning that if the goal was to have 12 people to listening session, that roughly 50% of them would be UMP, 5 or 6, because that would be representative of the total enrollment mix in the population, and that there would be 2 people from United and 3 people from, Kaiser. And so it didn't always happen perfectly, but that was the aspirational goal, to have that mix, which led to that type of dynamic and conversation for people to describe their experience with the plan and also hear about the other plans as well. So that was a very deliberate, purposeful recruitment kind of goal that was here for these listening sessions too.
And in fact, the representation turned out to be almost exactly 50% UMP. So that was pretty true to the expectation. Just as a reminder, the listening sessions were facilitated. We had an outside facilitator. His name is Noel Villarreal, and he's a contractor with Ernst & Young. And there were 5 facilitated questions. So it was basically, tell us what you like about the plan, tell us what could be better about the plan, are there any gaps that you can identify, and then sort of a general, what feedback would you like to give HCA or PEB or the board? What kinds of things would you like to tell us? Open-ended. And then the last one was, how would you prefer that HCA communicate with you? Next slide, please. Public forums were held on April 26th, May 17th, and May 24th. As you can see from the numbers, the turnout was way less than we initially thought it was going to be. We had 32 registrants and about 18 participants. The format was, everybody was given 3 minutes to make their statement. There was no feedback loop. We didn't ask questions, we didn't answer questions. The feeling is, don't have any, absolute truth on this, but the feeling is that people were less happy with that format. They really preferred the listening format. The people that generally showed up came to make a particular statement. Most people were prepared and had written statements that they read into the record. Our initial feedback was, not surprisingly, almost exactly the same, right? Keep options that work with original Medicare on the table. There was a lot of dissatisfaction with privatization of Medicare plans that was expressed. And there was a marked note of, please increase the transparency for HCA about what it does and how it does it, and especially the interaction with retirees. And finally, keep looking for ways to lower the UMP costs. Next slide, please. So we've been working, the outgrowth of the listening sessions and the public forums is there'll be a legislative report that's due on December 1st. But we've also been making interim changes. And so I wanted to just familiarize the board with some of these interim changes, things that we're doing. So on the website, we have frequently asked questions. These are questions that mostly arose during the listening sessions. And then we've identified some common Medicare myths. Again, what we have found from the listening sessions is a lot of people have misconceptions about how Medicare works or how the coordination with different plan types works. So we're trying to address some of that. The next slide shows where on the website the retiree engagement can be found. The next slide specifically highlights where the FAQs, the frequently asked questions, can be found. And then the next 2 slides, this is frequently asked questions. You can see that they are accordion files. There's a little down caret at the end, and if you press on that, that's where the answer would show up. And then the next slide is the myths. Again, these are Medicare myths, so meant to be sort of general, high level, how does Medicare operate? And that is the end of my presentation, unless there are questions.
Do we have questions or comments for Ellen? Yes, sir.
So I think one of the, and I'm sorry to come back to drugs again, but I think for a lot of people, one of the most confusing things as you engage in having to take prescription drugs is this whole concept of a formulary. And so I'm just going to throw this out and see what you can tell me. Let's say that I have to take warfarin, and let's say that person A is with Kaiser, person B is with Uniform, person C is with United, and person D is with Primera, and they have gone out on the market and gotten their own prescription drug. So I'm assuming that what each one of those how they will be covered will be different depending on the plan, and in some cases, where they are placed on a formulary will also be different. So when you decide, for example, to switch plans, you have to take that into account. And if you take several prescription drugs, you really need to do some research.
Absolutely, Tom, and that's why we try to encourage people. When I make webinars for people who are retired and thinking about switching plans, I talk about the kinds of considerations for making a decision whether to change or not. And one of the questions is you should get a list of all the drugs that you're taking, and you should go to the plan you're thinking of switching to and find out how those drugs are covered. For example, warfarin is a generic name, right? There are different formulations, there are different products that come out, there are different formulas of it. And so different plans will put that at different places or may have different copays. And the unknown for us is for people on the Medicare supplement plans where they get a Part D plan off the commercial market, because we don't have visibility into that. We don't know which plan they picked. We don't know where the formulation may fall within the tiers on that plan. So it's really important that people go to the plan that they're going to be dealing with and ask as many questions as possible, because that's the only way to know with some predictability what the coverage would be.
Thank you.
Thank you.
Yeah, Ellen, aren't there tools to do that? I mean, it seemed to me there were at one time where you could go to a website of the plan, type in the medication, and it would tell you what your cost would be.
Yeah, so with the caveat about cost, for United, for example, there is on their website a drug finder, right? And the only reason I say that a caution on the cost is you may have to look at 2 or 3 pieces of information. It will tell you the drug, it will tell you what tier it's at, obviously if it's covered or not covered. If it's not on the list, it's not covered. And then, you have the tier, then you have to go back and look at what the tier coverage is. And I believe all of the plans have something similar to that, so you can find out. What is harder for people is, I know that I take a blood pressure medicine. I don't know the exact name of it. I don't know whether, Kaiser calls it blood pressure X and United calls it super blood pressure. So there's no way necessarily that I'm really getting the best information. But that's why we tell people to call the plans themselves, because the plan customer service does have that kind of information and can help members navigate that system.
John, I saw your. Yes, Ellen, I had a question that's more general, and maybe I should have addressed it to Molly. How do you define a retiree for our program?
That is a great question, John. So we have actually 2 definitions, right? We have retirees who are Medicare eligible and on Medicare A and B, and we refer to them as Medicare retirees. So in our plans, you must be on Medicare A and B enroll in any of our plans. So that's a Medicare enrollee. There are people who retire out of either the K-12 system or public service before age 65. So they are non-Medicare retirees. Those retirees are grouped with the actives in the same risk pool, and therefore the plans that are available to them are the same as the plans that are available to active employees. The cost is different because they've lost their employer contribution, because they're retired, but their plan choices are the same. Does that address your question?
It does, but I have a more general question, and that is, how do you define who's a retiree? They have to have so many years of service?
So that is specific to the retirement system that they are enrolled in. So for public employees, it depends on, are they PERS 1, PERS 2, PERS 3? Teachers, it's TERS 1, TERS 2. I'm not sure if there's a TERS 3. So there are different retirement systems, each of which has its own definition.
Vesting.
There's vesting and different term, years that you have, different service levels. There are definitions in each retirement system of what separation is.
So it's different, it's not one size fits all?
It is not, and PEB does not make the definition.
Yes.
And in fact, John, there was a bill that passed the legislature on a specific plan type that is directly related to eligibility for PEB benefits. It was House Bill 1008, which was, Cade in his presentations described it as the concept of being able to separate from service and qualify for PEB coverage, retiree insurance, without having to pull on your pension was a concept that was allowed in Plan 3, whether it was CERS, PERS, TERS, but not Plan 2. And that bill changed so that you could separate, not pull on your pension immediately, and still qualify long-term for PEB retiree coverage. So that those are statutory definitions which are heavily rooted in kind of the inherent structure of the requirements for our pension plans that are monitored or administered by DRS, the Department of Retirement
And
Systems.
that's where that link occurred, was that, sorry. There we go. And that's where that link occurred, right? When you say, according to the plan, you had to be eligible to draw to be eligible for the insurance.
I can actually give an example of that. So, John, I started teaching, I was 21, and so I was eligible to retire at the age of 52, which I did. And so for 13 years until I was Medicare eligible, I was in the non-Medicare retiree pool. And so that no longer exists. The state came in and changed that, but for people my age in that generation up to 1977, anyone who began teaching before 1977 were automatically in that pool, and automatically after 30 years, no matter what their age was, they were eligible to be in the non-Medicare retiree pool.
Interesting, thank you very much.
Elliot?
Yes, I am now on a supplemental plan, and what was useful for us is getting, and I hope this isn't going to freak people out, a health care drug insurance agent who said to me and my husband, "You've got a heart condition, she's got this, she should be on this Part D, and he should be on this. You're going to get the best rates, each of you, based on the stuff you're taking." So we were just able to give him a list. Like you said, you have to go through every single thing you're taking. And depending upon your profile, you may get better benefits from a different Part D plan. That was very helpful for us.
Thank you for bringing that up, Elliot. I did want to say, to address the earlier question, that the Office of the Insurance Commissioner, Harry, you asked about, finding this information. The Office of the Insurance Commissioner has a website that goes through all the potential Part D plans that are available commercially to do exactly what Elliot just said, so that somebody can walk through on this plan, Plan A, I'm going to have these kinds of costs on Plan B. I'm going to have other costs to make that comparison. And the statewide health insurance benefit advisors, SHIBA volunteers, specifically work with retirees to help them navigate the Part D options. So that is a resource that's available.
Other questions or comments for Ellen? Ellen, appreciate all the work and engaging our retirees. Awesome.
Thank you so much.
All right, now we're up for call for public comment. Is there anyone on Zoom would like to provide comments? We're going to gather the list to effectively manage them. If you're virtual, please raise your virtual hand if you'd like to speak. And is there anybody from the public in the room that would like to speak? Seeing none, moving to the virtual land.
On the list.
Yep.
We're just gathering names right now for members who have virtually raised their hand.
Yeah.
I'm not sure.
Elliot?
Okay.
Do that.
Elliot's got a
While we're
question.
creating the list, Elliot, you have a
Okay,
question?
I have two questions I've been saving, and I think Dave knows about one. Senate Bill 5490 passed this session, as you know, and there are employees who did not timely notify HCA that they were deferring enrollment and then appealed. And I know they cannot enroll in a self-insured plan. I have had questions from members asking, okay, but what about open enrollment? Aren't all bets off? Can't we enroll in a self-insured plan at that point? Can you answer that question? I've read the statute. I think I know, but I'd rather not guess.
Thank you, Elliot, for not guessing. It's a great, statutory interpretation is, by definition, an interpretation sometimes, and what one person thinks is clear is not necessarily clear. So this was actually a great opportunity because turned out there were multiple interpretations of the statute. But the way this is being implemented is that the initial enrollment will need to be, there is a part of the bill that dictates that the enrollment needs to be in a Medicare supplement or a Medicare Advantage plan. And so that will be for the initial enrollment. And then after the initial enrollment, those individuals will be able to change plans as if they've been in the pool the entire time. So that's how this bill and that statutory language is being interpreted for this population.
So I'm being pushy here, but could you put it on your website?
We're working on implementation of that very bill, and so we'll be getting there. We have some communications that are going to be rolled out.
I'm not saying right now.
Oh,
but
yeah. No. As we roll out
Yeah, right now, I want to,
No. I absolutely understand, Elliot. We're working on implementation of the bill and communications, and the fact that you kind of asked that question and wondered where that was coming, and I knew that I needed to be prepared to talk about that today. That'll be something that's part of the general communication as we roll out information about 5490's implementation.
Okay, and then I've got one more question, and I'll make it quick. ACO REACH is now becoming a problem for some members. And I'm not asking for a position, of course, but can you at least give some guidance for people who want to call you and say, I can no longer use my primary physician. What do I do? Where do I go? I'm living in Clarkston. I can't answer them. I don't have an answer. And I think if they had someone to go to, I'm afraid it would be Ellen again. Is there, can there be a resource where they can go?
So I don't have an answer for that one today, Elliot, but the good news is that we've been talking about that very topic and how to incorporate it. There's, I think, 3 more board meetings this season in general, and one of the upcoming presentations, we're trying to weave in some information about ACO REACH. So I know that the team is working on something to be able to describe that in the public meeting, so I'm going to defer to that work that's underway for that particular topic.
Any other questions or comments for the board before we go to public comment?
Can I just, I'm sorry to interrupt. We do have HCA PEB Medicare, that's all one word, HCA PEB Medicare at hca.wa.gov.
HCA PEB Medicare at hca.wa.gov is an email. Ellen's in the audience and not a microphone, so the public may not have heard her. But that's an email that's accessible for submitting questions that can help be vetted here by the team at HCA. AKA Ellen.
All right. Let's get to public comment. Matt, is it Grosjean?
It is. You pronounced it correctly.
It was a wild guess. Don't give me too much credit here. How you doing, sir?
Thank you. Thank you, Chair McDermott and the board members. I want to start out with kudos to Molly. That was an exceptional presentation of an extremely complex topic. And I was heartened to see that there are 3 states that do coordination of benefits with Medicare with a Part D drug plan. I'm going to write a letter to the board requesting information about this because I think it's really important, and I think it's sort of the elephant in the room, in that through the listening sessions, people are talking about how much they like UMP Classic Medicare, and they should. Regents does a great job. HCA does a great job with the plan. It's because of drugs, however, it's just incredibly expensive. But there are other states who have delinked the pharmacy from their Medicare or non-Medicare coverage, like UMP Classic Medicare. And the cost drops dramatically for the user.
Right.
And I think the other elephant in the room is that HCA, given their current resource level, I understand that. The answer is when somebody calls with questions about the incredible complexity of choosing the 7 different plans, I believe it's 7, it is call each plan. And so you're left without any help. And there are some people who are going to devote the time to wading through these masses of information, and even then you can make mistakes. The great advantage of having UMP Classic Medicare without a drug plan is that the UMP Classic Medicare medical part of it stays familiar with Regents, and yet for the drug plan, there's help. There's help not only from Sheba, there's help, individual help, also with private brokers. So you can say, I don't know what to do. Which plan should I get from the Part D plans? And there's somebody to hold your hand through that, because being told to call each plan, I think, is a very difficult bar, and that's not HCA's fault, but we need help. And so combining UMP Classic Medicare with Part D, I am urging the board to look into that and see if that's an option. I'm not trying to be Pollyannish here, but I do think there are other states that are doing it, and that would be a wonderful option for some of our retirees. Thank you.
Appreciate your comments, sir. Next up, we have Amy Fortier.
Hi, Amy Fortier, Chair McDermott, members of the board. I also want to commend Sarah Whitley and Molly Christie on the coordination of benefits presentation. The information is amazing and is going to take some time to digest. I see that Milliman is a font of information, and hopefully we'll be hearing more about some other insights that are received from that as we go on throughout the calendar year. I also wanted to commend Ellen. Thank you for the summary, for the listening session summary. I hope that there will be some more outreach to retirees between now and the compilation of the report to the legislature. And especially there may be some input from the 24/7 system. Also, as we continue throughout the next several meetings, there are a number of topics that will likely be addressed, and would like to see some outreach associated with that. Again, thank you, and look forward to seeing what we work on next.
Thank you, ma'am. Appreciate your comments. Next up is Lena Mulder. Oh, Linnea, sorry.
Thank you very much, Chairman and the board, for this meeting. I have one comment and one question. My comment, and this was Ellen's presentation, and Ellen, thank you for doing all the retiree engagement work you've done. When you're discussing, when formulary is being discussed, just because a medication is on a formulary does not necessarily mean that that your physician gives you the prescription and then you can just go to your pharmacy and get it filled. Depending on the medication, it may still require prior authorization. And it varies, prior authorization process varies greatly from plan to plan. And I think that it would be useful for members to have a link to the pre-authorization process for each plan. My question is to Molly. And Molly, thank you so much. That was a wonderful presentation. This is a really basic presentation, or basic question that maybe I could just get an email response later. I didn't catch why there is such a difference between the federal subsidy between the state coordination of benefits versus Medicare D plans. That amount of that the federal subsidy is 24 million that we receive, and Washington State pays 200 million. I mean, that does certainly show why uniform is so much more expensive. But probably everybody else got that. I didn't quite catch that. Thank you very much.
Yep, maybe you could go ahead and send Molly her email address is on her presentation. Send her the email, and Dave, maybe at the next board meeting, we can go over the response. So I appreciate your question and comment. Next up, Fred, Mr. Yancey.
Chair McDermott, members of the board, again, thank you for the time you give to this whole process month after month. It is tremendously complex, and I struggle often to understand, but I just wanted to add a personal kudos to Evelyn, Ms. Wolfhagen, for her outstanding efforts in outreaching in terms of the Medicare area. She's a real asset to the organization. I know she's just returned from presentation to the school retirees in Pasco, and she's made herself user friendly and accessible, and we very much appreciate her and know that you do or should. Thank you very much.
Fred, Ellen is not an app, but but she appreciates your comment and she is with us. Next up is Kathy.
Can you hear me?
Yes, ma'am.
Hey, I'm totally new to everything, including using the raising your hand and all of that. So sorry about that. So I really appreciate being able to participate. And there are a couple of things I'm new to. I want to say I'm new to being a retiree who's doing Medicare, even though I'm 72. Okay, so we just signed on. This year is our first year, and there are a couple of things I just wanted to bring up about the United Healthcare choices, the choice of United Healthcare, and some confusion and some, I'm curious about how you're monitoring how that's working out. And the one thing I want to say is that I'm confused about skilled nursing and drugs. The way that the United Healthcare states their pharmacy benefits is really confusing because it combines the Medicare D language with donut holes and all that stuff with at the end of their presentation, in their materials or your materials too, it basically says that there's a $2,000 cap on your drug costs, and that's in contradiction to Part D, rules which say that your out of pocket or combined out of pocket is $7,700 or something. So I'm just pointing it out, and I know it's something I need to call and figure out on my own. That's not your job, but I find it really confusing. Plus, I believe Medicare, the feds are trying to pass, or they have passed something where $2,000 is going to be the maximum out of pocket cost for Medicare. So I'm bringing it up as a statement and a question. I don't know if you've heard other people say they're totally confused. The skilled nursing aspect is also very confusing about, benefit periods, and United Healthcare says that they cover the unlimited unskilled nursing. And I find that really hard to believe, and I don't know what that really means. I understand what uniform offers. I've had uniform for 30 or 35 years, insurance. So the last thing I just want to point out, and that is of concern to me about, I'm trying to decide whether to switch to United Healthcare, is that the whole customer service angle of Regents versus United Healthcare. I don't know if you're tracking or people are letting you know if United Healthcare is really providing adequate or good or poor customer service. I had personally a very bad experience when I was trying to decide whether to stay on uniform or not with United Healthcare, when I looked into this a few months ago, which helped me decide to keep, Regents and United uniform. And I, compared to Regents, it was like night and day. And the other thing is that there seem to be a lot of problems with Optum going on locally and with United Healthcare as well. In media, you can read about it, that they have a propensity to deny benefits. And if you're diligent, about 75% or a large percentage of people get approved, but they are routinely denying benefits, supposedly, and it's a supreme hassle for people to get the benefits, approved, going through the process. And in terms of Optum locally, there are a lot of problems with how they're conducting their business with Polyclinic and doctors leaving Polyclinic and refusing. In particular, I have a doctor who's leaving several of my doctors have left there over the last year or two, but the most recent doctor is not going to accept United Healthcare from retirees when she's opening her own practice, because United Healthcare has been so hard to deal with from the provider end as well as from the customer end. So that's just 3 things that have been on my mind that I don't know if other people have brought this stuff up.
Kathy, we appreciate your comments. Thank you. All right. Closing, we have the 2023 board season schedule is posted on the HCA website and is always part of the briefing book, which is normally posted to the website on the Monday before each meeting. Our next meeting is going to be June 29th, 2023 from 9 to 1:30. It's going to have the same format, and attendance can be in person or via Zoom. Dave, any final comments before we head into executive session?
Thanks, Chair McDermott. I just wanted to highlight a preview of coming attractions for the June 29th meeting. This isn't everything, but these are some things that are anticipated. There were 2 resolutions that were introduced today, and we'll go through the stakeholdering process and bring them back and hopefully have the board take action on them, especially that COVID test one, which would have an implementation date of 48 hours later. The second is we're anticipating at this point that we would be bringing the proposed 2024 Medicare rates and premiums to the public board meeting then. Non-Medicare rates and for both non-Medicare retirees and employees wouldn't be until July, but we're anticipating Medicare at the next board meeting. And we're also anticipating talking some about a communication survey that we did of the PEB and SEB populations earlier this winter and some of the things we're learning and looking at implementing from that. So those are a few pieces. I also wanted to highlight that I don't want anyone to walk away and think that Ellen's presentation about our engagements was the end of our presentations on engagements. We will continue bringing you information about that as we're working on the report. The next steps for that report process is we're exchanging and working on finalizing the summary notes of the 24 listening sessions with the coalition that also had observers that were note-taking and doing that comparison and finalizing those notes. And then this summer we will be analyzing the information from there, and we'll be having conversations with that coalition that was supporting the listening session process to talk about the types of findings that we're anticipating and describing in the legislative report, simultaneously while we're working with Milliman on the other part of that legislative report about other options, which I very much appreciate what came in public comment from Matt. That is certainly an area that can be looked at. However, I just, in all fairness, John's question about individual impacts in any sort of pharmacy change is a very real one that would have individual member impacts, but it's certainly an area that I agree with Matt needs to be looked at and is something that very well could be, I expect more information about that as a potential option for consideration by the board at some point. Not for 2024, but that is kind of in the hopper for review. So just wanted to highlight those things.
Any other questions or comments from the board before we go into executive session? Seeing none, executive session is going to happen here in Sue Crystal Room for board members, and will include HCA employees. At this time, members of the public joining us in person at the Healthcare Authority Day, as well as employees not part of the executive session, will be escorted by staff to the lobby for the duration of our executive session. You'll be called back in to join Sue Crystal for the remainder of the public meeting, which will be intended only as a brief statement to formally adjourn the meeting after exec session has concluded. Pursuant to RCW 42.30.110, subsection 1L, the board will now meet in executive session to consider proprietary or confidential non-published information related to the development, acquisition, or implementation of state-purchased healthcare services as provided in RCW 4105.026. Exec session will conclude no later than 1:15. Board members, let's take a 5-minute break while we transition into executive session. Thank you. All right. Hey, folks, we're back, but we are leaving again. We're going to go back into exec session until no later than 1:30. So just letting the public know what we're doing. Thank you. All right, folks, we're back from, we green? We're back from executive session, and this meeting is adjourned. Thank you.